Welcome everyone to this fifth Lux-MicroHub webinar. This webinar is hosted by the LNS Microbiology department and aims at sharing scientific thoughts from different topics around clinical microbiology. I'm Guillaume Fournier, Scientific Officer of the Microbiology department, and today I'm really pleased to host the Professor Paul Wilmes as speaker. Paul can look back on a successful scientific career with over 100 publications. These steps were taken at the School of Environmental Sciences of the University of East Anglia in UK, the Max Planck Institute for Marine Microbiology in Germany, the University of California in the United States, before returning to Luxembourg. He's a professor of Systems Biology at the University of Luxembourg, where he leads a research group at the Luxembourg Centre for Research Biology. Although his specialty is the study of the microbiome and its interaction with the host, which is scrutinized by means of microfluidics, it is in his capacity as a co-speaker of the COVID-19 Task Force of Research Luxembourg that he comes to talk to us about the response of Luxembourg scientists to the COVID crisis. So, I let the floor to Paul. Feel free to ask your question in the chat during the presentation, and we will take the time to come back to it after the presentation. Thanks.
Okay, Guillaume, thanks a lot for the invitation and also for the introduction. And I guess you can hear me and you can also see my slides.
Perfectly.
Okay, very good. All right. Sorry? Right, that I guess means that I can go ahead. So basically, yeah, as Guillaume has already alluded to, I'm here as a representative, let's say, of the COVID-19 Task Force of Research Luxembourg. And I will basically talk a bit about our experiences in terms of the COVID-19 pandemic and how we contributed to the national response. Before I go into details in terms of what we established, I think it's important to just put oneself back into the shoes that were in March 2020, where there was certainly no lack of questions concerning COVID-19. And that in itself bred a lot of uncertainty that culminated, of course, angst. There was, of course, an immediate need to provide answers to this multitude of questions. And that is, in fact, how then very rapidly the COVID-19 task force came about. And I think it's fair to say that this was the first time that science really had a role to play in responding to a national crisis. So the COVID-19 task force was set up in March of last year, bringing together all of the major research institutions in Luxembourg, of which the LNS, of course, is also one. And the COVID-19 task force was set up to basically bring together the combined expertise within the different public research institutions to basically offer support to the healthcare system. And what is also important is that from the beginning, we had also a direct link to the different ministries and also the government, because the task force itself was supported, and then also directly we liaised with the Ministry of Higher Education and Research. And here is just a little bit of an overview in terms of its structure. So what was important is that we had basically defined contact points at the different research institutions, but then also within the ministries and within the hospitals. And this allowed then to have proper task coordination between these different actors, including, of course, also the hospitals. And what was important is that we had these contact points to facilitate fast decision-making, to, for example, initiate very rapidly distinct projects that covered elements that provided answers, for example, to the questions that I just highlighted. And all of this, of course, allowed rather rapid and straightforward escalation in, of course, very complex situation as it was unfolding. So here is a little bit the kind of hardcore of the task force. So there was Ulf Nervas as spokesperson and myself. And then we had an operational lead in the context task force, which was Frank Claude from LIH. We had as members Henri-Michel Cauchy, also Frank, of course, Lars Geffers, Jasmine Schulz, and also myself. And what you see is in relation to the members that each individual member also was in charge of coordinating different work packages that I will come back to in the next slide. Importantly, you see, of course, all of the different logos of the different research institutions on your left, and these were all represented and had a role to play, of course, in the task force. And then through the days and weeks of March, along with early April, we had to identify different work packages that would cover aspects that were very essential to again address the questions of which I gave you a flavor at the beginning. And so what you also see here is that there were diverse different work packages ranging from understanding more about the prevalence of the viral infection in the population. This is, for example, work package 1, which then led to the CONVINCE study and now has evolved into the Orchestra study. And that was, of course, important, but there were also very diverse other aspects that we wanted to make contributions to, for example, socioeconomic impact, which was assessed by work package 7, and then we had work package 13, for example, focusing on logistics as well as supply chains. And this is something that ultimately was leveraged in terms of a construct to basically address the fundamental question that was basically given to us, also from the government side, is when and how can we transition from lockdown to revitalize economic activity, bearing in mind that in March, April, of course, we were in lockdown. And so we went through the motions of basically getting data and answers to questions from all of the different work packages to go through the development of a strategy to be able to predict what might be happening after lockdown, then to prepare for such eventualities, and then also to implement a program that may provide some solutions as to how we could exit this in the safest possible way. So exit, of course, the lockdown. So in terms of what we provided immediately as output from the different work packages, I'll just give you some snippets of information. Of course, I will not be able, by any means, able to cover everything, but I think that this will give you a good flavor of what was achieved. Again, also there in a very, very short period of time. And one output from, for example, work package 6 was basically giving analysis results and also projections based on modeling to have an idea as to how the pandemic may evolve. And so in order to achieve this, an agent-based SEIR network model was developed by work package 6. So this is rather classical. I will not go into all too many details here. But one aspect that was very important, and I will be talking about large-scale testing later, which formed part of a strategy that we termed proactive mitigation. What we were trying to assess here by leveraging this model, for example, how many tests would be needed per week to basically identify, in particular, pre-symptomatic and asymptomatic carriers, and thereby be possibly able to break infection chains and thereby, together with the contact tracing, to suppress epidemic dynamics. And so here is just an idea to basically convey the message, and that we basically simulated many different scenarios. Here is, for example, without large-scale testing on the left-hand side. Again, look at the date. So this is after the time of exiting lockdown. Then with large-scale testing and contact tracing capacity up to 60 cases per day. And then you have the last scenario where you have contact tracing with a capacity of 120 cases per day. So this just gives you an idea of the fact that everything that we did in terms of formulation of a strategy was basically underpinned by data, and also in this context by this SEIR model that allowed us to make some projections as to what impact, for example, large-scale testing in the context of this proactive mitigation strategy may have. And then there are, of course, other actors, given that this is a talk at LNS. Of course, LNS has made major contributions in relation to providing information on the strains that are currently in circulation. We had also the Luxembourg Institute of Socioeconomic Research, which looked much more at the socio-economic impacts of the pandemic in the context of Work Package 6. Then another program or effort that proved to be extremely successful, and I also see that Leslie is on the call, as well as Malcolm, was Corona Step, and here it was aiming to basically provide information on the prevalence of the virus in the context of sampling and analysis of wastewater. And to just give you an idea that there's also, of course, some exciting science to be done here. Here is just an excerpt of a recent publication by this team, and where they were able to show that we're able to resolve signature mutations from individual SARS-CoV-2 lineages in wastewater, and thereby are able to perform wastewater epidemiology to get really a snapshot of whatever's going on in the population at a given moment. And then also other important contributions were made, for example, by the LNH I had already mentioned, now convinced. So this aimed at monitoring the spread of COVID-19 in the population, and then pre-COVID, which is focused on the severity as well as the longer-term health consequences. So this is just, again, a snippet of what was achieved. Unfortunately, today's presentation, of course, in terms of its duration, is not sufficient to cover all aspects. But it's important to nevertheless highlight that also in terms of outputs, we have been providing reports from all of these different efforts, typically on a weekly basis, but it might also be twice a week, such as, for example, in the context of Corona Step. And so these reports are provided to the government and are thereby, of course, also important for the government to assess where we are currently in relation to the national dimension, to this pandemic. So just to give you some idea of the most up-to-date data, so this is just from a synthesis report that we provide typically on Thursdays, and here you see, for example, on the left-hand side, that we're currently seeing a significant increase in daily cases. This is reflected in the effective reproduction number, which is on the top. Then this is also mirrored in terms of the case numbers in blue in the middle panel, along with in the wastewater, where you see the levels in red. And then we are also monitoring the situation in hospitals, where you see also that is in normal care, there was also an increase over the preceding week. And the other thing that we are doing, and that's more on an ad hoc basis, is that we are providing information as to where we are concerning different elements and different factors. And so, for example, here we've been looking at the waning of immunity. And what you see up until mid of October is, of course, that you see, broadly speaking, a reduction in the effectiveness of the vaccines. This is, of course, for those individuals that received a vaccine. And the point there is, of course, we've been more recently, and I'll show you just some elements from Alex Lupin's and George Gonsalves's group on assessing the impact of booster shots. And what is clear is that booster shots are obviously important to keep our population-wide immunity high. Another aspect that both Ulf and myself were really heavily involved was outreach, and this is something that does still continue. And I didn't want to basically bore you with all of the different press articles. And what I was just surprised is that we found we got some attention, I should say, in a number of international media outlets, such as me being quoted here next to the now President Biden in Time magazine, where we were highlighting what we're aiming to do with the proactive mitigation strategy, which included the large-scale testing. So that does lead me on to the strategy, and I just wanted to explain to you how we went through the motions, which data we considered in designing this program. So basically, this is what we were confronted with in April 2020, and these elements were, of course, decisive in the formulation of our strategy. So first of all, what we knew by that time was that the SARS-CoV-2 virus exhibited very high infectivity with R0 values or basic reproduction numbers well above those for influenza. What was also really unclear at that moment in time was the case mortality rate. And depending on how deeply people had sampled their populations worldwide, the case fatality rate fluctuated between 2 and 10%. So 10% would, of course, been very, very devastating. I will show you later that our data now from Luxembourg says that the case fatality rate for Luxembourg, where we have very high case ascertainment, is approximately 1.2%. The other thing is, in terms of COVID-19, which is, of course, the disease caused by the SARS-CoV-2 infection, here a lot about the etiology was unknown, and therefore also it was unclear which treatments may work. The other aspect, and this was apparent very early on, is that infected individuals that might not have had any symptoms at the time of diagnosis were nevertheless infectious. And so it is clear since then, of course, that pre-symptomatic and asymptomatic individuals are majorly responsible for transmission. And so the point is that in trying to figure out how to best mitigate the epidemic spreads in the Luxembourg population, especially after the lifting of lockdown measures, what became apparent was that we had to figure out a new consequential approach. And so some of the conclusions that we reached with internationally leading experts, because we were also advised by, for example, individuals such as Mark Lipsitch, who's the world's leading epidemiologist on coronaviruses at Harvard, we were concluding that we had to basically leverage population-wide RRT PCR testing strategy, whereby we figured from the simulations that we should cover about 10% of the population per week. And also what was clear to us was that looking at antibody levels across the population was not considered a priority, because at that moment in time we were, of course, witnessing extensive epidemic spread. And so such a testing strategy wouldn't have had any tangible and immediate benefit. So the point is that we had to figure out how to, in order to achieve the testing capacity, that we had to develop some form of PCR pooling process, and also finally, of course, a lot of operational competence was required to guarantee a smooth pre-analytic workflow. So basically, just to give you an idea of what the impact of whole testing on the population might be. And the emphasis here is on broad testing. So this broad testing does include population-wide screening, such as large-scale testing, but it does not just include that. It does also include, of course, broad availability to testing, which is something that Luxembourg really put in place very early on in the pandemic. But let's just focus on the first the image on the left. So basically, within the population, you may have symptomatic individuals, you may have pre-symptomatic individuals, and you may have asymptomatic individuals. And it's very clear that basically from either of those individuals, you can, of course, get other people infected. Now, the point is, with the classical approach, you would only be able, of course, to put the symptomatic individuals into isolation, and thereby then the pre-symptomatic or asymptomatic individuals can carry on and infect others. And that then leads to the fact that you nevertheless get the establishment of infection chains and the sustaining thereof throughout your population. So the point is, it's a race against time to basically limit, in particular, the pre-symptomatic and asymptomatic individuals of going on to infect others. We do, of course, know that, and that is something particular about an infection with SARS-CoV-2, is that we have a very long incubation period, which is typically 5 days. So you can imagine that if people are positive and they are going on to infect others, if they are asymptomatic or pre-symptomatic, this poses a major, of course, challenge. So the point is that you want to be early, you want to detect in particular the pre-symptomatic and asymptomatic individuals early, and thereby suppress the epidemic dynamics and basically suppress the curve. So that was the first and foremost aim here also of the large-scale testing. So it's important that all of this was basically built up from scratch. So the large-scale testing itself, along with, of course, all of the other testing that was done, including at, of course, LNS, but also in private laboratories. But for the large-scale testing, we basically had to put everything in place from the get-go. And this just gives you an idea of the challenges that were faced in developing such a strategy that would allow, again, a capacity to at least test 10% of the population on a given day. During 1 week. So here's basically the testing station, and many of these testing stations, 17 during phase 1 of large-scale testing. And so large-scale testing in phase 1, that was the time that Research Luxembourg, in particular LIH, was in charge of the program. This lasted from the 27th of May until the 15th of September. And here you see one of the test stations, the one in Laboratoire. On the 15th of September, the program was handed over from Research Luxembourg to the Ministry of Health. And we have, of course, looked in depth at the data relating to phase 1 of large-scale testing. We are also in the process, also together with colleagues, for example, now at LNS, we are also looking at the data covering phases 1 to 3 of large-scale testing. Important to stress here is, of course, that after the lockdown, we see that we have an epidemic curve or increase in the summer months. And so this is particular, but it does allow us, therefore, to assess the efficiency of the program. So how we went about this in terms of figuring out what would be the frequency by which we would want to invite individuals to take part in the large-scale testing. So again, this is mainly aimed at people that would have not had any symptoms at the time of testing. So based on social connectivity, we were able to identify basically 3 main groups. The first is a high-risk group. So this is a group comprised of people that have, due to their profession, for example, many interactions with other individuals, and therefore have a high risk of basically getting infected and then also going on to infect others. And a classic example here are, for example, healthcare workers. So those form part of the high-risk category. Then we have medium risk. So this is basically people that would have, for example, been in relation to lockdown already been working for quite some time again, together with others. So where there was no way whereby they would have been able to do telework, for example. And then we also had the sampling of the general population at a lower frequency. And what this allowed us to do is to assess whether there were any regions of the country where there was a higher prevalence. And if so, we could also go in with a high test frequency to basically identify again mostly pre-symptomatics and asymptomatics, and thereby also in those areas break infection chains. So basically, in terms of a few numbers here, the capacity that was established allowed the testing of about 10% of the population per week. We had this 3-pronged strategy that I just highlighted, and overall, the workflows that were established allowed us to establish a work routine that worked almost flawlessly. There was, of course, some issues at the beginning, as would be normally expected, but these were overcome very, very rapidly. and this then meant that we were producing on a regular basis high quality and reliable test results. So I'm not going to go into all the details here in terms of the numbers. I just want to say that basically approximately in phase 1.5 million indications were sent out, and the numbers of individuals that participated were approximately half of the population. And due to large-scale testing along with the linked contact tracing, we were able to identify around 1,100 positive cases. The other aspect that is important is, again, that what I had already highlighted was that we classified the people in relation to the infection frequency into 3 groups: high risk, medium risk, and general population. And so we were then able to look at these individual sectors and see whether actually our prediction in terms of where there might be the highest levels of infections, whether those were in fact validated by the actual testing or whether there were deviations. And so there were quite a few unexpected things, but most of it was expected. But the highest basically prevalence was continuously found to be in the administrative and support services activity sector, where you clearly see that you have a high number of infections. But other sectors which we had thought that would be high risk actually did not stand out. So, for example, in the first wave of SARS-CoV-2 infections, there was clearly a higher prevalence of COVID-19 among police officers as well as pharmacists. And that didn't manifest itself over the summer wave. And that means that although these people, of course, still continue to have a lot of contact with others, what happened was they had in place a number of very clear measures to limit their exposure and then also them going on to infect others. So here is basically the overall result slide in some respects. So basically what we were able to do was to basically have approximately half of the population, just short by 1% really of half, so 49% of residents participated. Among the cross-border workers, there were fewer, only 22%. But basically what large-scale testing in terms of positive cases among residents and then also some of the cross-border workers allowed us to do was to identify through also contact tracing approximately 1,100 cases, which during that summer wave that I already highlighted represented around 26% of those cases. But it's important also in this context to stress is that those cases would have gone on undetected, of course, it had not been for large-scale testing, except for maybe that some of these individuals would have developed symptoms, by which time they would have, of course, again, infected others, and so would have never been able to as conclusively to track contacts and also break infection chains. Okay, so the results from the analysis that we did, this was based on both the CQ values, but then also the detailed contact tracing data that was collected by the aspects of santé. What our data suggests, of course, there is always a question over whether you have a clear idea of asymptomatics, but I mean, the prevalence thereof within the population. But what we can definitely say here is that based on our data and in relation to specifically the contacts, that asymptomatic and presymptomatic carriers compared to symptomatic carriers basically infected on average a similar amount of others. Then we were also able to look at what might be factors that would contribute to people being tested positively. And so, for example, of course, some sectors that have a high social connectivity, we did indeed see higher levels. So, for example, in healthcare, also hospitality, as well as construction. And then also what was quite stark is that there was definitely a socioeconomic gradient whereby people with a disposable household income of less than 30,000 euros per year had also a higher risk of being tested positive. Because of the population-wide SEIR model, we were also able to assess what was the impact of large-scale testing and more broadly of this proactive mitigation strategy during that summer epidemic wave. And so basically, by having broken the infection chains very early on, the data here suggests that numbers would have been on the order of 43% higher without the large-scale testing. So this is based on, of course, simulations, but importantly, the model is clearly parameterized with the relation-wide Luxembourg data. So this is rather solid, in fact. The other thing which I wanted to highlight here in terms of cost is that colleagues from the LISA calculated that lockdown itself cost the economy about 3,200 euros per Luxembourg resident. And then, of course, the opportunity cost here seems compelling if you compare that to the cost of a test, which every Luxembourger would have, or resident at least, would have been entitled to over the course of phase one, which then again was the large-scale testing there as part of the proactive mitigation strategy was introduced, of course, to basically suppress the epidemic dynamics and that we would have more sectors be open. So this then, of course, continued. I showed you the pictures of the handover. So this is just a summary for phase two. I mean, there is, of course, also phase three. But importantly, phase two, of course, was around this time last year, where you also had a very clear increase in numbers. So basically here, 2.1 million invitations were sent out. You had a lower participation rate of about 30%. But nevertheless, given also that, of course, there were many, generally more cases, due to large-scale testing, 9,200 positive cases were identified, and that corresponds to about 20% of cases. But again, this allowed us just to suppress the curve sufficiently such that we never were in a situation whereby, for example, hospitals would have been completely overwhelmed. Of course, the pressure was already great, but without this kind of buffer, it, most likely would have been much, much more severe. Okay, so the point is that not many countries, although right at the beginning of the pandemic, the need for doing population-wide screening was immediately recognized by all leading international experts. But it's important to stress that not many countries were able to pull this off. So there is a few examples. So one is Liverpool, which comes, I think, the closest to the large-scale testing. So this was run as a program between the 6th of November 2020 and the 30th of April 2021. And here, about 57% of residents, so this is about 300,000 individuals, took rapid lateral flow tests. So, of course, the testing strategy here was different. They had thereby, of course, also lower, in particular, sensitivity, but also specificity. And of those that took part, 47% had more than one test, so that were also, for example, healthcare workers. Important here is that 150,000 approximately residents had to take a PCR test, either because they had symptoms or because they had a positive asymptomatic lateral flow test. And what is interesting is that among those 6,300 individuals that did not declare any symptoms were tested positive by rapid lateral flow tests, so that were then also later confirmed by PCR, and about 23,000 individuals that declared symptoms tested positive by PCR. So they also did an analysis in terms of impact. What is interesting is that, of course, numbers-wise, there are some similarities not released in relation to the impact. What is also important is that our phase one lasted for about 3.5 months, so approximately half the duration of the program in Liverpool. And what they found was that based on their results, that they had a 21% reduction in cases up to mid-December versus control areas. So what that means is that generally speaking, the numbers, if you do a comparison, if you were to also take into account differences in sensitivity, specificity, you will see that the advantage of such a large-scale screening program in comparison also to ours is, of course, given. The point is also, and that is very similar to what we saw, was that test uptake was lower. At the same time, infection rates were higher in socially deprived areas. Then last but not least, another program that involved population-wide screening was the one run in Slovakia. This was very different from both the effort in Liverpool as well as in Luxembourg, because here the program was only performed within 1 week and allowed the screening of 65% of the whole population, and basically by the identification of positives, as well as then, of course, them going and contacting their contacts, so they didn't have a formal contact tracing procedure in place similar to that we would have had in place. But basically, they, based on their analysis, see a decline of prevalence of 80% through such a program. So the point is that we have also an awful lot of information on asymptomatics, and this allowed Claude Müller, most of you will know Claude as a virologist in Luxembourg. And what Claude was able to do is to look at this data, compare it to other published data. And what he concluded was that there's not much difference in viable virus, which is shed from symptomatic or asymptomatic individuals. What he also hypothesized is that about 3 in 100,000 asymptomatics become long-term carriers of the virus. And these individuals may be responsible for setting up virus reservoirs that themselves can then fuel future outbreaks. So this is, of course, something that we wouldn't be as worried about right now, as we are seeing again a rapid increase in cases, but this might be something to, of course, also look at for when cases come down again. What he also concluded is that during an acute phase of COVID-19, asymptomatic individuals should definitely be included in this testing strategy through, for example, large-scale testing. And he also concluded that, or this is more actually my conclusion, is that we need to learn much more about the role of pre-symptomatic carriers in the fueling of the epidemic. Other research that stemmed from this was, for example, work done by Lisa on what are challenges in terms of incentivization, so to how to get people to take part in such a large-scale testing effort. And what came out of this analysis was that age, altruism, conformism, and the tendency to abide by government-imposed rules were actually leading reasons why people wanted to get tested. And then interestingly, the people that did not take part or that did not really want to get tested, here the leading reasons were risk aversion, unemployment, and conservative political orientation. And so what is also interesting, I will just touch upon this, is that maybe similar reasons in terms of the demographics are at play in relation to people's reluctance to get vaccinated. So the other thing is that because we did such a broad testing, we can then also estimate at the level of the population what the general impact of this was. So in phase 2 of large-scale testing, they also did serology, and thereby we were able to estimate seroprevalence. And here the numbers, that are provided, excuse me, are provided up till the 15th of January, which is the time that vaccination kicked in. And so this is reflective of a sampling of approximately 1,000 individuals per week. So you had 7.7% that obviously seem to have had exposure to the virus up to that point. And so basically, if you compare that to the case numbers that were determined up to then, you can see that the case ascertainment was almost complete for Luxembourg. So it's basically fractions of percentages that we would have been off. And so if you do the same exercise, for example, for Belgium, for which there was some data, for other countries there was not, in Belgium the discrepancy is much, much greater. The other thing is that, and I touched upon this already earlier, given that we have such clear case ascertainment that allows us also to get reliable data on the case fatality rate, which according to here our analysis would have been at 1.2% for Luxembourg. And this is in stark contrast to the surrounding countries where case fatality rates, according to the data, are much higher, so at least double that of Luxembourg. So what can one conclude here? I think it is still safe to conclude that large-scale testing was the only feasible strategy if one wanted to suppress epidemic dynamics by testing and contact tracing, because of the fact that non-symptomatic carriers are infectious. And this may also be one of the reasons that we were able to basically keep schools and shops open while France, Germany, and Belgium had to go into lockdown. So it'll be interesting to see, of course, what happens in Luxembourg over the coming weeks. So I'm almost at the end. I'd just like to say that this is not the end. In fact, I started with all of the questions that were in the room at the beginning of the pandemic, and unfortunately, there are still many different questions that have yet to be answered. And so basically, we're still in a time of great uncertainty because we are, of course, also now seeing the resurgence in case numbers, and we're not clear, whenever this may end. So where are we at? So generally speaking, worldwide, more than 250 million individuals have had COVID-19, and with more than 5 million deaths. In Luxembourg, we've had on the order of 85,000 cases, and well in excess of 850 deaths now. Vaccination campaigns are advancing, but herd immunity will be difficult to reach. We can maybe have a discussion about that later. Variants of concern represent a threat, in particular in relation to the dominance of the Delta variant, which is, of course, much more transmissible. Breakthrough infections are shown to correlate with a decrease in antibody titers. That is clearly the case after 6 months, but is obviously for some vaccines, such as for Janssen or for AstraZeneca, is on the order of 3 to 4 months, by which time you do not have any protection, or the effectiveness of the vaccine against infection is basically zero. And so basically we have waning immunity that is obviously a real concern. And then there is quite a bit of debate over booster shots, but here in Luxembourg now the decision has been taken, and that is that boosters will be given. So the other thing that I just wanted to touch upon, and this is obviously going to be a challenge for the years ahead, is that many patients who survive the initial infection do not fully recover, and they experience a spectrum of symptoms that is basically represented here on the right-hand side. And long-COVID symptoms may include fatigue, headaches, anxiety, shortness of breath, loss of smell or taste, as well as cognitive impairment. And it's the latter which is, of course, a major concern, considering how we will deal with this in terms of its longer-lasting effects in the years to come. What is also important is that these symptoms may affect hospitalized and non-hospitalized individuals, as well as symptomatic and asymptomatic individuals, and therefore this is an important public health issue. So if we just do the numbers for Luxembourg, long COVID generally is thought to affect about 25 to 40% of COVID-19 patients, and therefore we may expect around 25,000 individuals in Luxembourg that are experiencing some long COVID symptoms. And so Luxembourg already in August launched a pilot project for the multidisciplinary management of long COVID, and this involves the consultations at the CHL led by Shoutouts, but also involves the Reha Center and the domain Mondo. But on our side, also together with, of course, and all of the other partners, we have now basically launched the Cuba Study, which is aiming to understand more about basically vaccination as well as the longer-term health consequences of COVID-19. And this is basically summarized in the context of two main research questions. The first being, what is the short-term to mid-term impact of vaccination in relation to the evolution of immunity and breakthrough infections by variants? and how could this knowledge be used to inform future vaccination in Luxembourg. Then research question 2 is focused on how we can use a better understanding of the symptomatology, prevalence, and socioeconomic factors of long COVID for enhanced prevention, diagnosis, prognosis, support, and treatment of this, what we term nevertheless a public health emergency. And so you see that there are 4 main topics that are being addressed, ranging from long COVID specifically to vaccination, or in topic 4, for example, tackling the socioeconomic determinants of long COVID as well as vaccination. And what is important is that all of the infrastructure that was put in place in terms of data flow specifically to basically analyze large-scale test data, this is now being leveraged in the context of this study to basically bring together individual cohorts such as Orchestra or Convince, Freddy COVID, as well as looking at health individuals to basically get population-wide overviews, given that most of these studies are representative, but then what we're also doing is interfacing this with the microdata platform of the Aspects en général de la sécurité sociale, and thereby are able to get unprecedented insights into these 2 main research questions. We just give you just snippets again of what some results tell us. So this is data from Anja Leist at the University of Luxembourg and her team looking at vaccine reluctance and hesitancy. What came out of this was a clear education gradient. And just to highlight that people, for example, with a relatively low education generally give as the main reasons for being reluctant to get vaccinated, that they do not feel well informed about vaccinations in general and not specifically informed well enough about COVID-19 vaccination. So this is all stuff and information that has already been discussed with the respective ministries, and where already measures are being taken to take this information into account in how people may be better informed. The other aspect that we've basically been heavily involved in over the course of the last week was to assess the effect of booster shots, not just specifically on the individual, but also what is the impact going to be on this new wave that we're in, and will booster shots, for example, in relation to the impact specifically on providing additional protection against infection and thereby also transmission, would that also be a very effective mean of pushing down the curve? And our data does very strongly suggest that it could have major impacts on case numbers, then of course also hospitalizations, intensive care unit occupancy, and also death. Okay, this brings me on to the conclusion. So basically, I think it's safe to say that in the pandemic, the Luxembourg's academic institutions, ministries, and the government were able to implement and execute an entirely novel mitigation strategy with a very minimal time delay. That all the participating organizations, as well as the Luxembourg population, participated in this program to establish a kind of a routine to deal with the pandemic. After initially low attendance, the test campaign turned out to have worked well, almost flawlessly, producing high quality and reliable test results. And all of this information is, of course, now a resource for other researchers to use. And so, according to our analysis, at least of phase 1, we were able thereby to suppress this early summer wave. Then broad testing and contact tracing led Luxembourg to have a very high case ascertainment, and there is quite a bit of evidence to suggest that so far the crisis management has worked quite well, basically through having such high case ascertainments based on the broad testing and systematic contact tracing strategy. Of course, contact tracing at times did get to its limits, but nevertheless was able to recover relatively quickly. Avoidance of multiple lockdowns was achieved, and this is obviously in very stark contrast to the neighboring countries, and allowed us to have a close to normal life as possible. whereby, of course, schools, except for 1 week where one school vacation was extended, have always remained open. Okay, so Luxembourg, by having only screened and by continuing to screen its population, so it's not that large-scale testing ended formally, but we have not had many tests being carried out. There's still a lot of testing, for example, in schools and other places that also, if you have just any hint of a symptom, you obviously are able to get a test. But it is also important to stress that through this, we have unprecedented data, and we can, of course, also thereby study what are the longer-term health effects of COVID-19, especially emanating from asymptomatic cases. It's also important to highlight that comparable results were obtained in other countries and regions, although, of course, our program in relation to the proactive mitigation and more specifically large-scale testing was based on RRT-PCR testing, so with higher, therefore, predictive values than the programs in, for example, Liverpool or Slovakia. Of course, now it's important that we gain much better understanding of the impact of vaccination as well as the longer-term consequences of COVID, and that's, of course, something that is tackled in the Lux study. So finally, I'd just like to conclude on the fact that we went from a multitude of questions to providing data that itself formed the basis of evidence that also then led to concrete answers in relation to the questions, and then was also the basis to formulate concrete solutions. And all of this was, of course, achieved in a very, very short period of time. So with that, I have a number of people to thank, of course, and I will certainly not go through the motions and reading out all of the names. There's a few of you on the call, of course, today, and I've given also some specific shout-outs already. I also nevertheless want to also thank our research group very much for their understanding and also the funding agencies for being quite flexible. At the end, I'm not an expert, certainly in virology, epidemiology, and also certainly not on coronaviruses. Of course, I've learned an awful lot. So as most of you will know, my work focuses primarily on microbial ecosystems. And a question that I get a lot is, of course, will this ever end? Will we get out of COVID? And we will get out of it. We work, for example, here on looking at immunity within microorganisms. This immunity is conferred by the CRISPR locus, which is in essence a bacterial or archaeal immune system, and we are able to track the evolution thereof in relation to corresponding bacteriophages, for example. And what we see is bacteriophages are, of course, very good at suppressing certain community members. So basically by killing them all off, which is typically known as kill the winner, but then very few members of the community through their specific CRISPR locus, the spacer complement therein, are able to recover, and thereby the whole population recovers. So we have, of course, vaccines which allow us to evolve this type of immunity much, much faster without having to go through many, many deaths. And this is, of course, something that we need to be very cognizant of, and is one of the reasons that we will get out of this, and rather sooner probably than later, but we do need some patience, especially over the coming months. And with that, I'd like to thank you again for the invitation and also for your attention, and we'll be happy to take any questions. Thanks a lot.
Thank you very much, Paul, for this presentation. It was very great and very broad picture of all the research topics that have been reached in Luxembourg. And thank you very much. I will maybe just start with a short question about the impact of the LST in the pandemic. If now you would have to look at backward on the strategy that have been used, would you change anything to the LST strategy or not, based on what you know today? And
I mean, what we know today, I think, would even further reinforce the notion to do, for example, large-scale testing. Even now with vaccination, of course, most of the breakthrough infections will be, leading to asymptomatics more so. So I don't see any compelling evidence at this moment in time why that would have not been a good strategy. I think what we've learned certainly is that some sectors are much more prone to have higher prevalences than others. And I think there might be some fine tuning and tweaking that one could do. The other thing is, I also think that we haven't got yet all of the data together. I mean, we are in the process of analyzing now also phases 1 to 3, and maybe there are some things that would come out of that one would want to change. But in the broader lines, I mean, we were of course no longer really actively involved in phases 2 to 3, but what is clear is that most of the elements that were developed for phase 1 of large-scale testing, they were continued, and they were continued not for the sake of, of just carrying on with business as usual, but there were of course clear reasons why one would want to do that. And the evidence that we've provided in the context of our paper, of course, underpins all of that.
Great. I would like to, as there is not too much participant, I will be interested in if there is any people who want to take the micro. And so I saw a message of Enzo. Enzo, do you want to speak, or do you want me to read the question?
I mean, I see his question, so I can read it out. So is there a genetic screening approach envisaged to identify genetic profiles that favor contamination or immunity to COVID-19, and on a model similar to the large-scale testing? So this is a very pertinent question. I mean, what we do really not know much about at this moment in time is what is the reason that you get a severe outcome in terms of the disease. And so, of course, genetics may play one role. What we definitely know is that there are certain, let's say, comorbidities that lead to a higher risk of developing severe COVID. And you know all of this already. I mean, there's not been all too much change there since the beginning of the pandemic. I mean, some people, for example, with longer-term pulmonary issues, chronic diseases that are related to that, they have mostly been removed. But for the most part, it is the case that still, like, for example, obesity, type 2 diabetics, then people with kidney disease or whatnot, they have, of course, a much higher risk. So, and cardiovascular conditions. But what is the underlying reason for others also that are people that are typically considered really healthy, why they would develop severe COVID is a whole question that is still not answered, I think. And so, yeah, genotyping would be important. And we are also doing this in the context of studies that we are doing. And we are, for example, looking at co-infections. But to basically do that at the population, I agree that that would be, of course, very insightful, but at the moment it's not planned to be done at the whole population level.
Thanks. I have another question from Michelle Conan. How did you identify false positive, and how did you deal with them?
Yeah, so the question over false positive, false negative. So what we did see is that the sensitivity and specificity specifically of the kit that was used along with the pooling strategy was very high. So that's the first point. And then we looked at the data, of course, to see whether there were basically individuals that would have had a positive and then subsequently would have been tested negative. And what we found was that this was basically absolutely minuscule. It wasn't even a fraction of a percent. It was on the order of 2 or 3 individuals. And even there, we wouldn't have been absolutely certain that those would have been false positives, because it may be that just they wouldn't have had after the time period that we looked at, and this was basically after 5 days, and that within that time period, basically their symptoms and thereby the viral load that they would have had, or not even the symptoms, because these were actually asymptomatic individuals. So by that time, they wouldn't have had any active viral shedding anymore. Yeah, but it's a perfectly valid question, except for that we wouldn't have had any evidence that would have suggested that we would have had any significant number of cases.
Great, thank you. I have a few questions. I don't know if there is other question in chat. I have one or two questions for you, which is about the vaccination. It's a little bit more about the sociological aspect, because we are far at LNS from the sociological aspect, except Arda, which made a little study on that point. But did you have been touching the sociological aspect by the COVID task force, especially the hesitation of the vaccination? Is there something specific to COVID, or is it the same kind of argument that we are hearing for other pathogens?
Well, so I mean, this is a very important point, and we are dedicating, I mean, since the beginning, a lot of efforts in trying to understand socioeconomic determinants of why people might have gotten infected, right? And so I highlighted, for example, people with a relatively low income, they have a higher risk of getting infected. That may be due to the fact that they have to go back to work properly very early on, but there may be, of course, other aspects of this that they don't understand the sanitary measures, they don't follow them. I mean, these are things that that are known. The other point there is that what we see in relation to specifically vaccination now, this is the work of Anja Leist here in the context also of the Cuba study. What she shows is that there is also clear education gradient, whereby people with a relatively low level of education, they say that they are generally not informed about vaccines as a whole, and then specifically COVID-19 vaccine. And so that means that one probably will want to think in terms of communication about using even simpler to understand language and try to maybe specifically approach those individuals in one way or another. And last but not least, I would say that we also know that particular parts of society now are very prone to believe whatever they're fed in terms of disinformation, for example, on social media. And Anja did a more detailed analysis there, and she found, in fact, that everything that we read about in the media, you know, about Bill Gates, a reduction of the world population by half, chipping, all of this stuff is really in those domains, and is a real concern, because I'd also think that it would be very hard to reach those people. And so this is where, I mean, I'm certainly not a sociologist or psychologist, so I don't know what one could possibly think of. But what recently worked really well in Finland is, of course, that scientists took over a much more active role on social media, basically explaining things in relation to their research projects, for example, in simple terms. And maybe that is something that one could try, but I'm not sure whether these people that have really made up their mind, because they're quite stubborn, of course, I would think, by now, that I don't know if we really will be able to convince them something to be seen. Yeah.
Okay, thanks. And there is something in the chat. Yes. I will read it for the record. So we know that some virus infections are potentially involved in the late onset of neurodegenerative disease. There is an interesting epidemiologic topic there. Beside long COVID, is the community planning to address this on the longer term in Luxembourg?
Yes, we are, and that is the Cuba study that we are specifically looking at this, and there is quite a bit of, I mean, that's why I also highlighted that there, as part of long COVID, there is this notion that people, I mean, this is also recorded, right? I mean, that people have a reduction in their cognitive abilities, for example. So there is some suggestion already there that it has a at least a relatively short-term impact. And the major question indeed is what is going to be the impact in the longer run on the brain, and may this be a kind of a ticking time bomb in relation to neurodegenerative diseases. So this is also the reason that a lot of people are, of course, arguing for really restricting and limiting the number of new infections, because this is something that is at the moment quite unknown, what the longer term population-wide impact of this can be. What we do know is that a number of long-term COVID sufferers are, for example, really hampered in their ability to work. And that is already the case now. So we don't really know what are the general repercussions for the longer term. And so that's where everybody that has looked a little bit at the data is, of course, advising caution.
I have a last question about which links between the two last questions. It's about vaccination and long COVID. Do you know how much the vaccination is protecting from long COVID? Is it similar to the protection to the symptomatic, or is it completely different? Did we have already some feedbacks from research on that topic?
Yeah, so there is some data that does suggest that it does. I mean, that vaccines do confer some level of protection against also long COVID, because also generally when you have the infection is typically more mild. So that of course has also a possible link to the actual long COVID symptomatology. But generally speaking, this is not entirely well known at the moment, because also people that, and this has been shown, that may be asymptomatic may indeed develop long COVID symptoms. And so this is actually where, in relation to the Cuba study here in Luxembourg, we're in a good position, because we have this really deep sampling of asymptomatics, right? And so we will be able to say much more than other countries on how high the prevalence is of long COVID among vaccinated individuals where breakthrough infections have occurred.
Okay, great. I don't see any more question in the chat. I have plenty of questions, but I think we already get. There is another question, so I will push for this from the Alliance also. Will it be possible to cross data of the LST with preventive health research or epidemiology data, for instance, in vitamin D, zinc, or and other basic micronutrient depletion?
Yeah, I mean, so what is definitely being done, not necessarily large-scale testing, because large-scale testing, there wasn't really much metadata that was recorded. The point is here, nevertheless, that Convince and COVID are indeed basically using quite a few questionnaires where a number of different health metrics are recorded. And in particular in Convince or Orchestra, as it has now become, this is quite solid data, and one is able to, of course, look at these types of questions. I'm not sure with respect to the micronutrients if this would be fully covered, but definitely whether people are taking dietary supplements, etc., that is definitely at least included in the questionnaires. So this is certainly something one could look into, yes.
Thank you, Paul. Is there any other question in the chat, or because I think I think we had a lot of discussion already for more than 1 hour, so I don't want to exhaust you. Thank you very much for your presentation. It was very informative, very well done. Thank you. And it was a pleasure. And I hope we will get you another opportunity with you to speak about microbiome and human interaction. So thank you very much, Paul. Thank you everyone for your presence and following this webinar. And I hope see you in the next webinar. Bye.